All right, welcome to part 3 of our training about COVID investigations and outbreak response in Montana. In this portion, we will talk about outbreak response, surge capacity. We'll address some of the special settings and considerations that may be part of an outbreak response. So we'll begin with the outbreak investigation portion of it. And just a brief reminder, as you remember from the first portion of our training, that we went over the different public health laws and authorities. Just a quick reminder here that public health has the authority and is required to investigate cases of communicable diseases in Montana. We had outlined those in the Montana Code. Again, a reminder, Montana Code, MCA, and then the Administrative Rules of Montana ARM. We will be referencing some of those as we go through the outbreak training module here. And what I also highlighted back then was, in the introduction, that what public health may be doing, some of the authorities they have, that part of the measures that they may be doing to control the spread of disease could be limiting contact between people, closing buildings or canceling events, or instituting quarantine and isolation measures. So again, keep that in mind with what we learned in that first module as these apply here in the outbreak response. There are different steps in an outbreak investigation. In some training modules, you may see more than the 7 steps, but we just wanted to kind of highlight sort of the big ticket items that are part of an outbreak response. Again, these are not set in stone per se, but it just kind of introduces the different components of the outbreak response. And this is something that we do on a regular basis here in Montana. We mentioned earlier, not to the magnitude, of course, as we're seeing here with COVID-19, but it certainly is something that is sort of the general flow that we tend to follow in any sort of outbreak investigations. So the first thing we usually do is confirm that there really is an outbreak, and we'll talk about what that means, what an outbreak really is. There's a task force that is established, and that we'll go into that in more detail, what that might look like. We talk about establishing and maintaining communications. This is a huge component because no outbreak response is ever done by one person. So communication is really important, and we'll see that we stress that throughout this course. And then, of course, we want to, manage those persons who are ill. How do we deal with that? How do we track that information? And, conducting the investigation, how did they get sick, or what's causing the illnesses or this outbreak? And what we then do to prevent any further transmissions. And then finally, of course, we monitor the response. And that's something I always kind of think of like a wildfire when we talk about that. The wildfire's been put out, but the firefighters never leave until like all the embers have completely been gone. So we always want to make sure that the outbreak's truly over before we walk away from it, so to speak. So we'll go into all those in a little bit more detail one by one, just to kind of highlight how outbreaks are usually being addressed in Montana. So the first step is we want to confirm the outbreak. And a lot of times, of course, when we talked about disease reporting and how we hear about communicable diseases, we already mentioned that laboratory specimens are often involved. Usually somebody gets sick, they go to a provider, they get lab testing done. And then, of course, there are so many different diseases that can spread, between people, between animals and people, and food and people, and so forth, right? So there are different mechanisms depending on what organism is causing the illness, what the symptoms are, that a provider might order laboratory testing. So usually we do look for laboratory confirmation, but let's say somebody's reporting in a school nurse is reporting there are a bunch of kids that have respiratory illnesses, and it's a lot of kids, something that is kind of out of the ordinary. So when that's being reported, because that is reportable as well, because there's a potential outbreak here, but we don't know what's causing the illness yet because we don't have laboratory specimens. So then in the administrative rules, it talks about that infection control measures should still or need to be implemented based on what we know, about respiratory illness and how we may address that without knowing what actually is causing that illness. You heard earlier, coronaviruses cause the common cold. It could be an influenza virus maybe that's causing those respiratory symptoms. We may not know the moment we hear about an outbreak, but we still, especially in congregate settings, need to employ those control measures. So the local health officer, when they hear about it, they will then make recommendations of what should be done, you know, maybe disinfecting, cleaning, visitor restrictions, and so forth, to make sure that we can kind of sort of stop the situation as we're finding out more of what's causing the illness. So then the big question that we often get is like, what is an outbreak, right? I mean, it's this general term that we throw around, and there are some definitions which we'll go into, but the reality of it is oftentimes it's a little bit more fluid definition, and I'll show you here why. So the CDC does have some outbreak definitions that they listed for COVID-19 specifically, which I have presented here. And in this situation, for example, they're saying that as you know, you're doing case investigation and contact tracing, which we learned about in the previous module, when you identify that 2 or more of those contacts then confirm as active COVID-19 cases, that would be then considered an outbreak. So that would be one approach, one definition, sort of where you could say, okay, I've got an outbreak situation. Another situation may be where 2 or more patients are discovered to be linked. So let's say maybe there's a workplace, somebody went in, got tested positive for COVID-19, and now another person unrelated, you know, not connected, not found through case investigation, also goes to the provider. They become, you know, are tested and they're positive. And as you talk to both of these folks separately and individually, right, you learn, oh, they work in the same place. Now you have, of course, concerns that there's maybe transmission occurring at that facility. So those would be some definitions that you can work with through CDC. In Montana, we do have outbreaks defined, and this is where it gets a little bit more generic and where you really kind of need to look at your local epidemiology, because it's not always the same depending on where you are, and I'll explain why. So in our administrative rules, we define an outbreak as the occurrence of more cases of a disease than would normally be expected in a specific place or group of people over a period of time. So always look at number of cases, right? The illnesses in a certain place over a certain time period. Those are the 3 components that you always look at. And this is where it can be kind of different depending on where you are. And this is where every local health jurisdictions, as they do follow up, would address this a little bit different and may kind of pull that trigger to that outbreak response at different times. So for example, if you're in a large county, large jurisdiction, it's October, you know, it's starting to begin to be flu season, and you're beginning to see, you know, influenza illnesses reported to you, and you may see 10 reported cases in one day. But that may or may not be unusual for that jurisdiction at that time. If it's in October or another time during the regular influenza season, maybe you already had some reports of cases and we're like well into December or February, and you have all these reports coming in, but that's not out of the ordinary. This is not more than you expect. You expect illnesses of influenza in that time period, and depending on your county, 10 cases may be what you see on a daily basis at that time. So for every influenza season, there's not an outbreak. Now, let's say you're in a small jurisdiction, really small jurisdiction, you see very few influenza cases at any period of time, even during your flu season. And let's say it's July and you are starting to see 10 reported cases in one day. And maybe even all these cases, as you learn more about them, maybe they're all connected to a certain like facility. That's a different situation. It's an unusual time of the year. It's a much higher volume for you. Very unusual to see that many cases in that time. So I'm saying this just to give you an example of how this can vary. It could be a condition like an organism that we haven't even seen in Montana in years, or something like a novel, right, coronavirus, like the COVID-19 disease. Those are things that, you know, if we haven't seen that or it's new, this is what we would consider, of course, unusual. And as you see the numbers reported every day, we are in an outbreak situation. To have this many cases of a novel coronavirus in Montana is certainly unusual, and that's obviously no news to this group at this time. So that's kind of where, I know everyone always likes to have a very black and white outbreak definition, and there's some guidance there, but it really depends on your local epidemiology. All right, so let's say you've established there's truly an outbreak in your community. This is more than your regular case follow-up that you normally do. Understand that communicable diseases are reported to local public health every day, from Salmonella, E. coli, hepatitis, pertussis, maybe even, so depending on where you are, and that's where you have to kind of figure out where that threshold may be, where you kind of take the next step. So now you want to establish your task force. And when you hear the word task force, you may think of the governor's task force for this COVID response. Generally speaking, and of course, again, that goes back to the magnitude of this outbreak. For most outbreak investigations in Montana, the task force usually does not necessarily involve the governor, of course. It's more at the local health level. And depending on where the outbreak is or what is where it's affecting your population, you may have to adjust or invite people onto that task force. And of course, they could certainly grow. You may start with with the health department, some staffing in the health department, but then as you learn that there's activity in a certain let's say assisted living facility, then you may bring on other people who kind of help, that may be players in that part. So that's, again, is very fluid, and you have to kind of assess the situation as it develops. So what does the task force do? It's basically sort of the command and control center. Often they use the incident command system, the ICS structure, because you don't want to have too many cooks in a kitchen. Somebody has to kind of guide this outbreak effort, and that's where this task force comes in. A lot of times members have, technical expertise, political expertise. It really depends on what outbreak you're dealing with and what experts you need to bring in on that committee. Again, with COVID-19 right now, it's impacting virtually every single Montanan, right? There are so many impacts from health-related impacts, economic impacts, and so forth, that there are different members who can bring that expertise to the table. There are usually regular meetings. Usually there are minutes that are taken. You often, if you go on the webpage that we introduced in the last module, there are kind of these minutes and summaries that are published as well. So, you can see what's happening, what's going on. And really what the task force does is they assign, the investigation, how stuff needs to be addressed or tackled. When we talk about search capacity, it's not just one person doing this work. They look at communication. How do we communicate with whom, how often, what needs to be shared to make sure everyone stays informed with only the information that is necessary to share, right? We did talk about confidentiality, and that continues throughout this process. You want to look at your data as you're collecting this information and make conclusions about how outbreaks are being spread or what control measures may be effective. And then finally, when everything is over, usually there's a bit of a final summary is what you get. And again, it depends on the size of the outbreak. It may be like an after action report where you look at how did things go, where can we do this response better the next time. So that's kind of where the task force comes in. So the next portion, to me, is one of the most important pieces, really, because as you already see now, in outbreak response, this is not one public health nurse talking to one individual who is infected, about their exposures or what they've eaten or if they got the right treatment to stop the disease. This is a much larger scale now, and we have a lot of people who are involved, and it's incredibly important that communication is done well and frequently too. Of course, you have limitations, especially as the public health department. You can't share confidential information for the most part, as there were the exceptions that we talked about. But the general media, for example, certainly wouldn't get individuals' names. And then how do you address certain response? How do you keep folks informed that you're responding to the outbreak without, giving too much information away, to make sure people are still protected, because they have a right to be protected. It's their health information. So, and sometimes in outbreak response too, it's not all very pretty, sometimes things are happening, or they're happening really quickly, and how you can't necessarily keep everyone informed constantly. So that's why it's really important to have good communication set up, that the key players are informed, know what's happening, that people are not tripping over each other, and everyone knows, like, this is the path we're going, we're on the same path. So one big thing is about communicating. When you are reaching out and announcing, for example, your response to an outbreak, it also helps assure the population that something is being done. It doesn't leave the population in the dark. And though you may not be able to share every detail with the general public, you can let them know, we were informed of, these, we heard of a lot of diarrheal illnesses that all reported they went to the same restaurant. We are working on it. We are following up. We're investigating this. And that kind of helps the general public to know we're doing our jobs. We're following up, right? It also creates awareness, because it may help identify new cases. So in this previous example about diarrheal illnesses at a restaurant, maybe I went to that restaurant too, and I've had, some symptoms after going there, but I didn't think anything about it. But now that I'm hearing other people have had issues, maybe I want to consider going to a provider and get tested as well, so that, and that then creates more disease reports. You hear about more folks. It gives you more, I guess, data points, so to speak, more information from these patrons to find out, well, what did they have to eat? And that gives you a greater chance that you find out what caused the illnesses, because you need to find out what caused the illnesses so you can actually respond and control that situation. Is it a food product that needs to be removed? Are there cleaning practices that are not, up to standards the way they should be? So that's actually a good thing. You can use communication to your advantage. You can use media, including social media. We've worked on several outbreaks where social media, again, it could be a huge help and could also be a real big hindrance. Rumors travel very fast. And it's sometimes actually really beneficial to get your word out there and communicate responses earlier on before rumors that tend to often be incorrect, spread. There were outbreaks in community settings where the public health nurse communicated through social media, and that helped for the general population to know a response is underway. They talked about, maybe they went into the provider to actually get tested, and so forth. It really helped. So again, use it to your advantage. But it's also it's a two-way street, because you're informing others and also helps raise awareness in the general population that in turn will help you in your outbreak investigation. You want to provide periodic updates too, keep folks informed. The COVID outbreak is moving incredibly fast, and it's very challenging to continue with most up-to-date information, but daily new information is being updated and published to keep the public as informed as real time as possible. And then especially for larger outbreaks, or depending on your capacity, a lot of local health departments already have a designated public information officer, and they are really good help in this situation. They can help kind of filter some of the questions and address them, so you can continue on with your investigation work. Or they can be a spokesperson during media inquiries and so forth. So again, communication is incredibly important. All right, so now sort of to the I don't want to say, the bulk of the outbreak investigation, right? So here we have all these people who were infected with this disease, and our job is to make sure that these folks are isolated, we find their contacts, make sure it doesn't spread further in the population. And that's our whole goal, right? So of course, sick persons are the priority. You want to make sure that they can get the treatment that they need. Now, you're not the medical provider here, you may be, when we talk about ensuring treatment, it depends on what condition you're dealing with. There are some reportable conditions where the recommendation is treatment is the only way that we can stop that condition. Like, for example, sexually transmitted diseases, the recommendations that we have adopted are saying, you know, that this particular treatment is what the most effective, that's what should be administered to make sure that that person can no longer transmit that STD to others. But it may be in other situations, it's other things, and not always is treatment, you know, either recommended or required. But you want to make sure that sick person is taken care of, right? We want that person to recover. So, you know, getting them into medical care, and then making sure that they get whatever treatment that they need. So that may be more of a referral. But when you talk to them, and this goes back to the case investigation that happens, right? You have a report of a person who's infected with a disease that can spread to other people, right? So you record their signs and symptoms, you talk to them about, you know, what some of the exposures were, how they may have gotten it, and so forth. And as you learn more about the condition that is causing, or the organism that's causing the illness, let's say you heard about a respiratory outbreak, but now you know it is actually influenza. So now you can, you know, based on what we know about influenza, you want to make sure that what the most effective treatment is communicated to those providers. This is really important when you're dealing with something novel like COVID-19. You know, we're still learning of what is effective treatment. So as information comes out, that's shared with providers so they can take care of those ill persons and make sure they can recover. And of course, you know, your goal is you're trying to find out what may be a possible source. That's why you talk to folks, where they've been or what they've eaten, or, you know, depending on the condition that they have. And you want to make sure that that ill person is taken out of the population, right? That's why we isolate them, and make sure there is no other opportunity for that person to infect other people. Because when they do, and you have more cases that we then follow up, right? So this is how disease spreads. And then you collect that information, and you collect it on what we call a line list. So I want to talk a little bit about line lists, because they are incredible tools that we use in epidemiologic investigations. So what is a line list? I'll show you an example of one in the next slide as well. But basically, it's a way to organize data in an organized fashion, I guess is the best way to put that. So for each variable that you want to collect, and that's going to be, each column has its own variable. And here on the right side of this slide, you can see some of these are very basic and generic variables. Usually the line lists grow quite a bit as you investigate an outbreak. But of course, you need some unique identifier for that person, because that's how you kind of filter things and summarize data. But a lot of things that are collected are, you know, very basic, like age, gender, symptoms, when they were first ill. You may collect information about outcomes or complications like hospitalization and death. Laboratory results you may want to track here too. Not everybody may have a lab result. Again, depends on the outbreak situation. You know, at this point, every COVID case reported has laboratory results, right? So you may have collect information there. But this list can really grow as you move on. For example, you may have a foodborne outbreak, and you may initially just collect some general food information, but as you get more data and you learn maybe of specific food items that are more often repeated by the different people who were infected, and then you may start breaking it out, and you say, you know, tomato, you know, has its own column, yes or no. Lettuce, yes or no answers. So you start to kind of fine tune that a little bit to help you with your analysis later on. So the columns represent the different data points, what we call variables that you want to collect about each person. Now, each person has their own row, and each row is also called an observation. So each line on that line list is one individual. So, you know, of course, that person has, then you put the data in for that person, you know, depending on what column it is. It's best, and this becomes a useful tip too, especially when more than one person populate that line list. In a larger outbreak, it's very possible that more people are populating that line list. Keep the data entry limited. Again, more cooks in the kitchen, it does not really help. You know, it's a matter of simply misspelling something that can really make the data analysis more complicated. So sometimes yes and no answers are really good to collect, or limiting when you have date fields, you may want to, you know, only allow a date to be entered in that field. So, you know, you're not losing, if somebody has a typo or misspelling, you don't have a problem there. So that's kind of like sort of a tip, I guess, for using line lists. And again, these can change. You may add a person on a row that you later learn does not fit that outbreak definition. That person really doesn't fit into this particular outbreak. And then you have to remove that, you know, that line, that row for that individual. You may add or remove columns, you know, the variables, depending on what you learn. So there's flexibility there, but the key is, this is really where all of your data goes. And that's the information you can then analyze. You can then use that information to look at who is affected the most. When you look at the interim COVID reports, there's a lot of data in there that talks about how many, what is the breakup in race, you know, how many persons are affected who identify as white or as Native American. We know that because we're looking at that line list. We look at how many people identified as that one race or another race. Or how do we know how many people have been hospitalized? It's because we're tracking that information in the line list. So here's what a line list looks like. And this is just one example. This is an example from CDC for a nursing home outbreak. Again, you really have to kind of tailor those specific to your needs, but it's incredibly helpful. Another really useful tool for that is also when you sort of a process, you know, a column in there that talks about process. So maybe what investigators is that person assigned to, you know, so you know, okay, like, you know, that person, you know, this investigator is following up with that person. Or, you know, if there are different steps that you're doing, like person has been contacted, or, you know, waiting for a call back, or, you know, there may also be a way for you to manage sort of that workflow. So incredible tool. Line lists are wonderful. You know, we're always here to help. We can help create line lists for you, or help, you know, maybe give you feedback on line lists. And we certainly have lots of examples that we can share too. Incredible tool to do the work. All right, so that was managing sick persons. Now you still have to do that, you're conducting that investigation, right? Because you want to find out who else is ill. And there's a couple ways we can do this. You also want to make sure that you can find out the what the source of the outbreak is. And, you know, that's what we talked about. That's the whole, like, when we know where the source is, we can either remove the source, or, you know, other methods of that we can stop that outbreak. And then you also want to find out, you know, who else is at risk. So to identify additional persons, there's a couple different things that you can do. One thing that we have started to do with COVID-19 is we're conducting active surveillance. And just a real quick recap, and I'm not going into great detail there, but passive surveillance is basically when a provider tests somebody, and, you know, there's a lab report, and that gets automatically, per the rules, reported to the local health department. That's what we call passive, because it's kind of happening on the passive sort of mode. When we go into an active surveillance mode, that's when we as a health department really reach out to actively look for more cases. So you may have heard in the news with the through the governor's announcements, a lot of the testing that's happening in nursing homes and assisted living facilities. So that's active surveillance. They're actively going out. They're not all people are even showing, most of them aren't even showing symptoms. We're going out, you know, to test folks to see where is that virus in the community. That's one way how you can find more new cases, people who wouldn't have gone to the doctor, maybe they weren't very sick, or, you know, and that's a way to reach them. And this is also where you use a case definition, and I kind of mentioned it earlier when we talked about the line list, but you kind of have to set certain criteria in terms of who would be part of an outbreak. You can't count everybody, because then that's not defining, you know, the illnesses over in a place over time. It's specific to that situation. And so that's where you have to look at, does the person have to have certain signs or symptoms and or a laboratory result that would fit with this particular outbreak? This is what we're after. We're not trying to investigate everything. We're having an outbreak that we're trying to nail down what happened. You know, time and place, you know, and what is the cause of the organism. And that also can change over time. As you learn more, you may widen your case definition. You may include more people that you previously didn't think were part of the outbreak, but it's turning out they really are fitting in there. Or you may narrow it. You know, you may find, maybe you cast the broad net first to kind of find more cases, and as you learn, you know, that outbreak is really more, here's where the outbreak happened. You know, maybe your time frame, instead of going from July 1st through July 31st, you know, the outbreak really was more in a certain window in there. But again, this is not an Epi 101, so I'm not going to go into great detail here, but that's kind of, you got to have some criteria of when somebody qualifies to be part of that outbreak. And then same with contacts, you know, of course, you know, we talked about, this is where your contact tracing comes in. You know, you got to find those folks who are in contact with a person of COVID-19, right? Because we know how it's transmitted to others. That's how we find new people, right? Some of those contacts, they get tested and they may or may not come up positive and then are also a case. And then, of course, the other big piece in this outbreak or conducting the investigation is finding a possible source. With foodborne outbreaks, sometimes it could be a food product that, you know, you often hear about recalls, or maybe it's poor practices at a restaurant, that the whole restaurant gets shut down until they have their cleaning processes corrected. So that's kind of where this is coming from, because you really want to find the source. In person-to-person outbreaks, there's not going to be a single source. So this is where, you know, this case investigation and contact tracing really comes in. You're pulling those infected, kind of isolate them out of that population to make sure they can't spread to others. And then the other thing is you look at is, you know, who else is at risk? You know, somebody who did not go to that restaurant that had the diarrheal illness outbreak, they're not going to be at risk for that outbreak because it happened, assuming, you know, that's what you found out, right? It happened at that restaurant, and that restaurant only. It's not a food product that's been distributed through grocery stores. You know, but this again totally changes depending on what kind of an outbreak you're investigating. All right, so then as we're doing all of that work, and you can imagine there are a lot of people involved, a lot of work, a lot of time spent to find out what is causing the outbreak. Okay, now the key is we want to stop the infections from infecting those other people at risk, right? For COVID-19, it's just about everybody in Montana, right? So what can we do to make sure that that person here who has not been exposed, that they don't get exposed, right? So again, it depends on your population at risk. COVID-19 is a huge outbreak right now that is affecting every Montanan. So the key is, of course, when you hear about an outbreak, when you're doing these outbreak investigations, you want to step in right away to take some precautionary measures. You know, you may know more as you learn about the organism that's causing the outbreak to take more precise measures, but initially you definitely want to take some precautionary measures. You know, when folks are testing people who are symptomatic, like healthcare providers, you know, they're gowned up. They have personal protective equipment to make sure, you know, that they are not going to get infected. You know, everyone is being more cautious than, not that they're not cautious already before, but you kind of take that extra step before. You'd rather be safe than sorry, right? And then as you learn what causes the outbreak or what the situation is, then you can adjust your control measures. And that's why you're seeing different responses also with this COVID outbreak, for example. You know, we're going from isolating individual folks to a stay-at-home order where everyone, you know, is really please stay home, so we can limit that interaction between people. You know, now there's more talk about, you know, you're wearing masks, you know, to protect yourself and others. So there are different things. And again, this is very fluid. It's a fluid situation. You have to kind of look at what is happening in the community, how much is the organism spreading, how, I don't want to say controlled, but like how, you know, you really have to kind of gauge where you are in the outbreak response. And, you know, these control measures, they can have real implications, you know, and that's why it's really important. You're taking this course right now because, you know, because of COVID-19, right? And you're either, you know, investigating cases or you're trained as a contact tracer, but you have to realize this work, what I'm describing, is being done, happens every day in Montana, right? With the different conditions that are not COVID. And so there may be smaller implications, but if somebody, let's say a restaurant is being shut down because people have been getting ill, you know, those are implications for the restaurant too. But, you know, our goal is we want to protect the health of the public, you know, so there's always that balance where you have to, you know, what steps do you need to take, or should you take, or, you know, to make sure that we can balance that we protect the public, but you also need to make sure there are some steps we have to take to make that happen. Yeah, and then if, you know, as you're learning what the control measures are that are useful, you know, make sure you share that with your healthcare providers. And really another kind of key message here too is these public health measures, they really need to be fully embraced, you know, to make them work. When we talk about wearing masks or social distancing, it's not helpful when one person does it. It's got to be a community effort to make it work. You know, so that's another thing. It goes back to communication. You know, you can use that to your advantage to inform the public and make sure that everyone is on board. All right, and then finally, in terms of the big picture steps, you know, you want to monitor the response. You know, you may be going down a path in terms of investigating and controlling an outbreak, and then and nothing changed. That happened before. We had a norovirus outbreak. A norovirus causes diarrheal illness, and we took all the steps that we knew, scientific control measures that would have prevented the spread of illness based on what we knew early in the investigation. Come to find out, no changes. There were still ill people, and it didn't have the desired effect. And then we learned as we investigated further, you know, because it wasn't stopping the outbreak, that something entirely different actually caused the outbreak. And once that was identified and the control measures for that were implemented, illnesses completely stopped. So this is where it's really important. You gotta watch and adjust, you know, what control measures are working, and how, if new cases continue or if that's slowing down. And you may have to ramp up your control measures. You may go from case investigation to bigger closures, you know, canceling of events or stay-at-home orders and so forth. You kind of have to like adjust that. Generally speaking, though, an outbreak is declared over when there are no new cases identified during a period that is twice the incubation period. So you want to go with the incubation period for that particular condition. And again, it varies what outbreak you're investigating. Go with the longer end of an incubation period, because there's no one day, you know, there's always a range and different people respond differently. And you double that. So if there are no new cases for twice that incubation period, there's good possibility, most likely, that outbreak is now over. You're looking at 2 cycles of possible transmission that would have stopped. So again, coordination is key. This is never done as a solo shop. There are always a lot of players in this, and you need a lot of help. And make sure that all of these things are happening in coordination, that people know what the other person is doing, you know, so there's good flow and effective disease investigation. All right, so as we already alluded to earlier, in an outbreak response, there are always a lot of people involved. And when you do regular case investigations, you know, there's a certain volume that may be normal for your community, and that's most likely how your health department is staffed. But when you're in an outbreak situation, especially when it grows much faster than you anticipate, then you're talking about surge capacity. You really need more help, and you need more help pretty quickly. So we're going to address a couple ways, looking at who could serve as your surge capacity, and how, at what point you kind of trigger that. So some key considerations, about outbreak investigations and kind of COVID-19 in particular is, these case investigations that are being done really need to be swift, and they need to be thorough. It's not going to help when you get a case report of COVID and a week later you get to that person because you were so overwhelmed, right? Then that person had all this time to not be isolated, to spread the condition. So that's the key. You got to get to those folks right away, get them isolated right away, find out who they have contact with. That's what's going to make public health work. That's what makes the control measures work. Case reports can increase exponentially. Again, depending on the condition, one person could infect X number of other people, especially if they were, socialites maybe, spreading around, not knowing maybe that they were infectious. You could get new case reports pretty quickly, and your numbers can go up very fast. Now, on the contrary, if maybe you don't have a high caseload of COVID-19, you may be able to also interview cases who are not confirmed yet, but where you're kind of reaching out to folks who may or may not confirm. But if you have that time and resource capability, you could certainly do that, and it kind of gets you ahead of the game. But it's really important to engage with the community, again, that communication, letting them know that you're responding to an outbreak, what is being done. Those are some key factors that we wanted to summarize. And really, as we've seen with COVID-19, the reality of it is just about every jurisdiction that is experiencing cases, and especially a large number of cases, they are stepping into additional work. They need additional help to do that work, because this is clearly above what they normally see. So how do you identify some community resources? Especially earlier in the outbreak, we learned about some layoffs or where certain maybe government agencies, where folks could not go and do their work when they could no longer be in the offices, or were not able to telework or things like that. There may be other government employees that you can recruit to help because they were furloughed, for example. Public health students are also a really great resource that you could recruit. I mean, these are folks who are kind of learning all this information. They're already having that background in public health, but maybe not that experience yet. And this is a great way for both to help you and, of course, for the students to get that experience. Look at community volunteers, other partnerships with philanthropic or technology sectors. Again, it's important that you make sure whoever gets onboarded that you communicate confidentiality, the laws and your policies to them, because they would operate under your authority. Then you have to make sure that they're following that kind of confidentiality. But look also at other partnerships. If you need to isolate folks who live in settings where they can't be isolated, you may look at maybe you need housing for these folks, or maybe you have an influx of cases. So there's a lot of things to think about, of course. So here's for your case investigation and contact tracing. Here's just a small excerpt of a list. We will make resources available too that have a more lengthy or more exhaustive list of different folks in different roles and how they can maybe help in your COVID response. But kind of generally speaking, of course, you do have your public health nurses, disease intervention specialists, especially for STDs. You see a lot of folks with that title, and that's what they do every day. Like, they reach out to folks and try to find out who their partners were, make sure they get the treatment and so forth. And epidemiologists are also good resources. Those are all folks who are doing this on this case investigation, contact tracing on a daily basis. They would be really good recruits to kind of basically hit the ground running. But then you also have really good search capacity with some other folks who maybe just require a little bit of training, like this course that we're presenting right now would be a good training course, you know, to kind of get people up to speed. And that would be, you know, public health graduates, or, you know, some jurisdictions brought back nurses who have retired. You have community outreach workers, health educators, social workers. There are a lot of folks who are doing public health work or work similar to public health who could be recruited with just a little bit of additional training. Now, in a different category, and again, there's a complete list. There's a link below here that goes into that. There are so many aspects to all this follow-up, but for self-isolation and monitoring, so this is not reaching out, talking to somebody, explaining all the different isolation rules. It's not the case investigation, but just simply that monitoring, right? Some of these folks are being contacted or are contacted in the health department every day, you know, to talk about, check in, you know, with symptoms or other questions that they may have. Maybe new needs are identified, as you saw in our previous training module. Maybe somebody has social or other needs outside of the health and medical monitoring that, you know, a social worker could address, and so forth. So kind of look at those folks here. Again, public health nurses, outreach workers are good skilled staff that could pretty much hit the ground running. But there are a lot of other folks that you could tap into that might be able to help with this monitoring. And so at what point do you then scale up, right? At what point do you make that surge capacity where you need people? And what CDC is publishing as guidance is that, you know, generally speaking, we talked about timely investigations. As long as you can interview your COVID-19 cases within 24 hours, you probably have enough staff to do the work. But the moment that goes beyond that, and you kind of may see that you're falling behind because of the huge volume of cases that you need to follow up on, that could be your trigger to say, I need to build my surge capacity. I need other people to help me with the monitoring piece or the contact tracing and so forth. And that's why, you know, we have this course. You could kind of divide it out maybe into 2 job tasks. One is a little bit more complex than the other. You know, job task 1 could be your case investigation, because this is where you interview a client. They've been just diagnosed with COVID. They may have a lot of questions. Of course, a provider hopefully addresses a lot of the medical questions for them, right? But this is where you kind of talk about their exposures and all those contacts, right? This is where you want to talk about who they've been around, so you can collect that list of names and find those folks and notify them. The other one would be the contact tracers. Now, they don't have to go and they're not dealing with somebody who is ill yet at the time. They're not soliciting any contact for that person, because these are the contacts who are not ill at this time. But there's some other work that is involved, you know, that they make the referrals if they do get sick. So this is, you know, just 2 kind of different job tasks that you can maybe, you know, train people up. So when you need to bring that capacity in, they have been trained on that. And then some other items or tasks that you may think about. And again, this list is not exhaustive. There's way more in the CDC guidance document. But think about these situations. You know, what if you have somebody who is a high risk person that needs monitoring? Maybe that there's somebody in the clinical or healthcare field who can help you with that, because they may have more complex questions, you know, for those who are not medical providers. We're public health, we're not medical providers. You know, look at who's collecting your data and analyzing your data. You know, you're gathering all that data in the line list. You know, who's helping you analyze this to help you with the conclusions that you can make to effectively stop the outbreak. So there's lots of different players here, lots of things to think about. This is, again, where groupthink really helps. You know, you have your task force that can kind of look at this. But yeah, there's lots of resources available to you right now, of course. And we're trying to, of course, bring on more people who can do the work and can serve as a resource in a surge capacity.
Due to the surge that we are currently experiencing in Montana, it is important to remember that case prioritization and contact tracing can be used to help identify individuals who are most at risk or most vulnerable groups. Each county can elect to choose which cases they prioritize. This is one recommendation from the CDC. categorizing low priority, next level, and highest priority cases. Please check with your county to see what cases you are prioritizing, or if you're prioritizing at all.
Good morning, everybody. Thank you for joining us today. My name is Blair Tomczak, and I am a nurse in Toole County Health Department, which is in small town Shelby, Montana, central northern Montana. I'm going to talk to you today a little bit about our COVID-19 experience starting on March 25th. So how it got to us. We got a call the evening of March 25th. I think it was a Wednesday or Thursday. Who knows, because everything runs together. We got a call that we had a COVID-19 positive patient in our hospital setting. Through contact tracing, through our investigation process, we realized that it was in our hospital setting, but that person had also came from a assisted living setting. So not only are we in, one communal setting, we're now in 2 communal settings. Through our contact tracing and all of that stuff, we realized that it had spread like wildfire before we even knew that it was here. And a little backstory on why we even tested for COVID was because it was a rule out. None of the classic symptoms. She was just kind of on hospice, and we did it on a whim. And lo and behold, it came back positive. It happened in one of our legacy Montanans, and the rest is kind of history. Communal settings, as everybody knows, are so dangerous with any type of illness that can be spread, and COVID is no exception. So a little bit of our perfect storm experience was that our office operates on 4 people on a given day, which is small, as a lot of Montana counties are. Our director had resigned in February with her last day being April 1st. Now, mind you, COVID hit us March 25th. Terrible, terrible timing. We have no DES coordinator for our county. We had no director come April 1st. And through all of our contact tracing and our investigation process, we realized that one of our staff members of 4, so our director is out, one of our other remaining staff members needed to be on quarantine due to being a close contact to a positive case. So we were down to 2 people through most of our high time contact tracing, contact investigation process. A little history about me is I had only been with public health for less than 1 year. I started, I think it was June of 2019. So I didn't have a lot of history in public health. So we were running on bare bones for a while, which made us the perfect storm. We have had a history of some staffing turnover within our office. Our previous director had only been the director for a year. So I didn't have a lot of time to learn public health before taking on a director type role. The thing that saved our bacon was learning how to network on the spot. The state is big, the state is wide, the state is huge. And there's a lot of people that are new in public health, but there's a lot of people that aren't new in public health. And reaching out to those people and the state level leadership, they gave us everything we needed to succeed with networking, with guidance, with constant phone calls. What I learned through all of this is people are really willing to help you. You have to ask for it. You have to ask for it. You have to be bold in what you need. You have to tell them, I don't know what I'm doing. How can you help me? And they'll jump all over it. That was a great ally in our process, because without that, I would have been completely blind in all of this. Another kind of joy in working with small populations is that everybody knows everybody. Everybody is related to everybody. Everybody is so internetworked in jobs, in family, in community events. Everybody is so intertwined that we just know so much. And it's true for our surrounding counties as well. Surrounding county people work here. Our people work there. They come here for doctoring. They come here for shopping. We're so intertwined that our local outbreak branched out super quickly. And we all became really close partners with our other health departments because we were all dealing with the same thing. Just so happened that my scale was a little larger than everybody else's. Privacy. Privacy is so difficult to keep on a good day, let alone a COVID day. And because everybody's so intertwined, they find out about things through different things, or boards they sit on, or places they work, or just kind of through the grapevine. So there was a lot of people feeling like they were left out because they weren't told, or feeling like they didn't know what was going on in their own community. Our commissioners, asked us to update them daily. And I just simply didn't have time to do that because we were working with 2 people. And at this time, we built up to 29 cases over a period of maybe a month or so. So for 2 weeks out of that month, there were only 2 of us. And I just simply didn't have time to update them every day. So they felt like I was neglecting them, which was not the case. It just didn't fall to the highest level of priority. So we had a lot of partners, community partners, that were a little distraught with my department because they felt like they were in the dark. So once we were able to take a breath and pull everybody in together, we created how to keep everybody in the light. And that was very important for us and very pivotal for us because we had a really good plan after that. So one of the things is everybody wanted to know who the positive cases were. They felt like they were entitled to know who they should protect themselves against and who they should, watch a little closer. That's not the case because as COVID progressed, we realized that we had over 150 contacts who could turn positive at any moment. So what we decided to do with law enforcement was provide them with a list of addresses where people were not sheltering in place, but where they were isolating. And we provided that to our sheriff and our dispatch. Nobody else knew that information. It kept super private. We let the EMS know that if that address was called or they needed services or emergency help, that our dispatch would say, PPE required at this address, no more information provided. They didn't need to know who the positive person was in the house. They just needed to know that they needed to protect themselves for everybody there. And that was for EMS and law enforcement. And that was a really great bridge of, satisfying this need to know without giving them a need to know. So a little bit goes a long ways in how to keep privacy. People felt like they knew things when really they didn't know things, but it was enough to keep them involved and engaged and proactive. That was big. That was a big moment for us. Nobody felt mad or left out after that initial meeting, which was great. The other small county, small town concerns that we have versus the bigger counties and people with just overall numbers is that we didn't have other departments to come and give us a hand in this contact investigation. There were 2 of us and that was it. We did get our 3rd member back after the 2 weeks, which was huge. That was a great moment for us as well to get her back. So we didn't have a lot of backup help to help with contact tracing, to help with filling out paperwork, to help with public education. We didn't have a lot of that. So that's one small town thing versus big town things. Bigger jurisdictions can pull other departments in like WIC or like maternal child help or, just other departments. We didn't have that. We wear several hats in our department. And on a good day, we can manage those hats, but on a COVID day, we realize that there's simply not enough of us. Another small town problem is we don't have a lot of people to pull from. So after we realized through our in contact investigation that it was in our hospital, our nursing home, our assisted living, our 2 clinics in town, and then to a few community members, family members, that sort of thing. Once we realized that it was in all of those areas, everybody else was running on bare bones. So we couldn't even ask for their help because they were downsized so much. And that's where when we asked for the help and we asked for our needs, we got them because we got the National Guard to come in. We got Public Health Systems Improvement Office out of Helena provided my office with contract workers to help with anything that we needed. And what we determined we needed was public education, and they helped with that. I was direct with my needs and said, I need help, and I got it. I can't say that that's going to happen every time, but for this time, it was pivotal that we had that help, and they did amazing work for us. We don't have a PIO officer, public information officer for our county. That was definitely a need. Moving forward, we're going to try to get one. But a lot of those other bigger places have those in place already, and they just tap into that where we didn't. We also struggled with setting up incident command in our whole county because it was hit in all of these healthcare areas that would normally be our incident command. We needed more help. So we outreached and got a regional incident command set up. We got a JIC set up, which is Joint Information Center set up. And a lot of these things were so important in our whole process that we couldn't have done it without the networking and the support that we got from local level, regional level, and then state level. We had great amounts of help. One thing through all of this is that it really pays to make friends. It pays to network. It pays to know people. It pays to be vulnerable, to get yourself out there, to ask for it, because this was over our head. In more ways than one, we were in over our head, and we did get that help and support because we were direct in our needs and asked for it. That concludes my speech talk. I hope it was educational and you can pull something from our experience. The biggest thing is, make lots of friends, do lots of networking, keep lots of people in your circle because you never know when you're going to need to call on them. I hope that COVID doesn't affect you, your counties, your area, you personally, the way that it did affect us so much, because we had quite a bit of loss and heartache from it. So, remember to wear your mask, keep safe, wash your hands, and have a great rest of your day.